Good morning or good afternoon, depending on where your location is. Thank you for attending the second webinar on human islet isolation that's sponsored by VitaCite. A recording of the first webinar we did that Bala gave, overcoming the challenge of low islet recovery from young donor organs, can be seen at vitacite.com/webinars. A recording will be found on this site for later viewing, and feel free to send the link to others. Now, we should have a survey that's coming up just to see your polls. Hold a minute. I see we're filling out the polls, and we will share these results with you in a moment. And it really, the poll's purpose is just to get an idea of how many people are the level of involvement in these procedures. The focus of the webinar today will be on islet isolation from chronic pancreatitis pancreata. The total pancreatectomy islet auto-transplant is primarily practiced in the U.S. for a number of reasons. First, the procedure was developed at University of Minnesota. Second is minimal FDA oversight, actually, for this procedure. All you have to do is register with the FDA. Importantly, in the U.S., third-party payers do reimburse for this procedure. Medicare at this time does not, but the regular health insurers do. And lastly, as many of you know, we are a fee-for-service healthcare system. So actually providing more services to the healthcare, to the patient population gets reimbursed. In a recent survey that VitaCite performed on North American human islet isolators, where we had about a 50% response rate, we determined that about 40% of the human islet isolations performed in the U.S. were for total pancreatectomy islet auto-transplant, whereas the number in this same survey was about 3% in Canada. A survey taken in Europe in 2018 and reported by Nano et al. That was published this year in 2020 showed that about 10.6% of the islet isolation procedures performed for total pancreatectomy islet auto-transplant, with 11 of the 12 centers in Europe participating in the survey. So, ground rules before we start. The microphone for all the participants are off. If at any time you want to ask a question, we encourage you to use the live chat function. I may just pull up, I'm going to end the poll, by the way, and just show you these results if I can. If you don't see, I don't see the results showing, so I'll just tell you that of the audience that responded, 75% of them responded that they are involved in these procedures, whereas 25% of the people are just curious about what's involved in doing the procedure. So sorry for the interjection. So getting back to the questions, ask the questions at any time. We won't answer the questions till the end of the webinar. Bala is also attending this webinar, he worked very closely with Gopal to do these procedures. And if the webinar is for roughly 25 minutes, the webinar total is about 60 minutes. If we don't get to answer all the questions, we'll do so by email. So without further delay, I want to have Gopal do the webinar. And the important thing to realize his bio was on the lead-in page for this webinar. He himself has performed, over 500 islet isolations, first when he went to Minnesota in 2007, and this continued on in June 2014 when he moved to the University of Louisville. So without further delay, I will pass it on to Gopal.
Thanks, Bob. Good morning to everyone, and welcome for this webinar series organized by Dr. Bob. So today's webinar presentation title is Addressing the Challenges of Isolating Islets from Chronic Pancreatitis Patient. To start with an overview of total pancreatectomy and the islet auto-transplantation. Chronic pancreatitis is a relapsing inflammatory process that results in a variable degree of parenchymal destruction and irreversible fibrotic changes in the pancreas. So the major problem for the chronic pancreatitis patient is the severe abdominal pain. As you see it here in the picture, so there is an obstruction in the pancreatic duct that causes the enzyme to go for an auto-digestion, so that's how the exocrine tissues get damaged due to the severity of inflammation. So after, as you know, that this patient goes in and out to clinic to treat the chronic pancreatitis condition, after an attempt with all the procedure failure, so the final end stage is to remove the pancreas. So once they remove the pancreas, the procedure is called pancreatectomy. After removing the pancreas, the patient gets an iatrogenic diabetes, and then lifelong they have to take a digestive enzyme to digest the food. So to overcome this iatrogenic diabetes, a procedure, an adjacent procedure following total pancreatectomy was introduced by doctors David Sutherland and John Najarian from the University of Minnesota at 1977. So once after resecting the pancreas is sent over to the clean room facility, and the islets are isolated and it's infused back into the portal vein of the patient's liver. Then it starts secreting the insulin to regulate the blood glucose level. After total pancreatectomy and islet auto-transplantation, the quality of life for these patients drastically improves following this procedure. So here is a summary of clinical report published in 2012 from the Medical University of South Carolina, indicating that 80% of the case the quality of life was improved, and when the survey question was asked to the patient, so they're ready to take the total pancreatectomy following islet auto-transplantation again, and this 98% of the cases said yes, they're ready to go for islet auto-transplantation. So even after undergoing a series of ICU and hospitalization, so they're ready to take this procedure. So this procedure is regulated by FDA as a 361 product. As Bob mentioned earlier, it requires it's a minimal requirement of a clean room system and a quality system. It requires and does not demand the GMP lab to do this procedure. And this is a publication by Morris et al. It's a meta-analysis of report of the success of total pancreatectomy following islet auto-transplantation. From this report, it's indicating that the principal factor responsible for treating iatrogenic diabetes was islet mass transplanted. The greater the number of islets, the higher the likelihood of insulin independence. So the pictures presented in this current slide and the subsequent slides, the works carried out at the University of Minnesota and the University of Louisville. So here you can see the grass morphology difference between the chronic pancreatitis pancreases versus the healthy cadaveric donor pancreases. So depending upon the severity of the inflammation, so you can see the changes in the morphology. So we need a modified technique to isolate islet from this type of pancreases, especially the severely fibrotic pancreases. The presentation is focused only on severely fibrotic, how to isolate the islet from the severely fibrotic pancreases. This presentation is not focused on a minimal pancreatitis or a pediatric cases. So the agenda of this presentation is to review on the microscopic changes that are found in the adult CP pancreases and the standard versus the modified islet isolation procedure used to isolate islet from the severely fibrotic pancreases and the lessons learned from at the University of Minnesota and University of Louisville, and to share an out-of-box method if at all procedure fails. And this procedure is just for a discussion and it's unchecked it. So in the subsequent slide, so we will have a detailed discussion on that. So here you see the gross morphology between the cadaveric donor on the left side versus the pancreatitis pancreases. Due to the inflammation process, you see the texture of the pancreatitis cases. These are the different cases are presented here, shows the firmness of this pancreases and the dilated duct. So it's extremely hard to isolate islet from this using a standard islet isolation procedure. So we need to have a modified procedure from the standard islet isolation method to recover islet from these type of pancreases. So here, so we present the histopathological analysis from a series of severely fibrotic cases comparing with a normal pancreases. On the left, you see a normal pancreases with the intact islet and surrounded by an exocrine acinar tissue, whereas in the chronic pancreatitis, loss of acinar tissue and the various degree of fibrosis depending upon the disease progressions and condition. So still you can see an intact islet, but you cannot be able to recover this islet due to the damage in the duct. We cannot able to infuse the enzyme properly. So based on the histological analysis, so here it's indicate that so there is a various degree of fibrosis in the severely fibrotic cases and a loss of exocrine tissues and ductal changes. So we need a modified islet isolation procedure to isolate islets on these type of pancreases. So degree of fibrosis and acinar atrophy affects the islet yield. So the more severe the fibroid, the number of islets, it's less. So the islet masses depend upon the degree of fibrosis. In minimal cases, you tend to get more number of islets compared to the severely fibrotic pancreases. The same, the acinar numbers is reduced in the severely fibrotic cases. So in the standard procedure, we use one full vial of enzyme. Historically, liberase HI was used to isolate islet. So it contains 2000 unch unit of collagenase and 11 milligram of thermolysin. So later, once the liberase HI was withdrawn from the market, so the enzyme was introduced into individual vials, was provided into individual vials as collagenase and neutral protease. So in the standard islet isolation procedure, so with the pressure controlled enzyme distension is followed, and the distension time is 12 to 15 minutes. There is no parenchymal distension, but we need a slightly modified approach to isolate islet from this severely fibrotic pancreases. So here, so we dose the enzyme depending upon the severity of fibrosis. In case of severely fibrotic, so it ranges, so we choose greater than 26 unch unit per gram. So due to the obstruction in the pancreatic duct and the dilated duct. So we have to use a hand syringe enzyme distension method to make sure the pancreas get enough enzyme for digestion. So we prolong the digestion time to 30 to 40 minutes. Then we continue to have the parenchymal distension to make sure the enzyme distribution evenly throughout the pancreas. Then if it's necessary, we do an enzyme recirculation. These are the different stages, approaches we do in the modified islet isolation procedure to recover islets from severely fibrotic pancreases. As you see here on these images, so these are the severely fibrotic. It's most of the time the pancreas comes with a dilated duct, and the parenchymal tissues are replaced by the fibrous tissue. So when we did the histopathological analysis, so it's indicate most of the time islet isolation from the severely fibrotic pancreas is end up with a lot of undigested tissue. When we process the undigested tissue for histological analysis, still it contains a lot of good intact islets, but we need a modified approach to recover this islets from the severely fibrotic pancreases. So we dose the enzyme based on the severity of fibrosis. In case of severely fibrotic pancreas, we use a max enzyme dose of 30 Wunsch unit per gram and 3 DMC units per grams of neutral protease. So new enzyme mixture is the predominant enzyme mixture we used to isolate islets. This enzyme was initially introduced in 2009 to isolate islet from the autologous islet isolation. So we published in 2012 about this enzyme. So this new enzyme mixture is comprised of intact C1, C2 collagenase from Vitasite and Serva neutral protease. Using this enzyme, we successfully isolated a higher number of islet compared to the other enzyme combinations presented here in this graph. So even in a recent publication from George Wilhelm from the University of Minnesota indicated that so till date, so they have been using the new enzyme mixture to isolate islet from their chronic pancreatitis pancreases. In the same publication, so this is the table, so it's indicating that using this enzyme mixture, we can able to successfully digest 90% of the cases. So the digested pancreas weight using this intact enzyme was 90%. So compared to other enzymes, so it shows a better digestion in terms of digestion as well as yield. So this is for the severely fibrotic pancreases, so it works well. So in order to match the currently available proteases to the standard dose that we have been following to isolate the pancreases, standard isolation, we use less than 20 Wunsch unit of collagenase and 1.75 DMC neutral protease. So in case of severely fibrotic pancreases, we use a max dose somewhere ranges from 26 to 30 Wunsch unit and 3 DMC unit neutral protease. To match this dose with the other currently available proteases, this table was prepared so you can compare the BP protease, the equivalent dose with the Serva DMC unit. So it's presented here for the standard dose as well as the max dose. So the enzyme distension is the key step. So based on this step, the rest of the procedure depends upon. So in case of severely fibrotic, so it's dilated duct, so putting the enzyme through the pancreatic duct is extremely difficult. So even when we get a pancreas with a duct, so we start the ductal distension, then followed by a parenchymal distension, prolonging for 30 to 40 minutes to make sure the pancreas gets a uniform distribution throughout the pancreas. So these are the other examples that we get from the severely fibrotic pancreases. So we use an interstitial distension using a syringe with 14 to 16 gauge needle and the enzyme. This is like initiating the digestion step at this stage. So we initiate this interstitial using the hand syringe method. As you all know, in the severely fibrotic cases, the digestion time is prolonged. It takes a longer time to digest the pancreas. When we do a longer time of digestion, it tends to damage the islets. So we follow a recirculation approach to collect the islets. It's released earlier to prevent the damage, and we continue to do the enzyme recirculation to digest the entire pancreas. We follow the enzyme recirculation approach to recover the maximum number of islet and to have a better digestion of the pancreas. And the lessons learned using this modified procedures, dosing the appropriate enzyme based on the severity of fibrosis, then using a hand syringe, because in severely fibrotic cases, the ducts is collapsed. Most of the time, we have to use a parenchymal distension to feel the enzyme pressure. So we use the hand syringe method and the prolonged distension of 30 to 40 minutes and following an enzyme recirculation to collect the released good islets to overcome the over digestion. And this is an out-of-box method. So Dr. Bob McCarthy got this procedure for discussion for this webinar. So this method was published in 1981 by Dr. David Hinshaw. So in this method, after the failure of initial enzyme attempt, they use a mechanical digestion approach. So using this method, they processed 5 chronic pancreatitis pancreases and successfully isolated islets from 500,000 to 2 million islets and transplanted. So here's the detail of this procedure. So at each time, so even when we get a pancreas ranges from 40 to 60 grams, so they use for each process 10 to 15 grams at each process. So this pancreas is minced and undergoes several washes and centrifugation procedure at lower speed and higher speed to recover the islets. After recovering the islets, they pooled and washed and infused back into the recipient portal vein. So the whole procedure takes 2 to 4 hours to isolate the islets. So after making this attempt, if it's not successful, so the author suggested to repeat the procedure to recover the islets. This is unchecked. It may be a good option for severely fibrotic pancreas because in most of the time it's ends up with undigested tissue. So maybe we can attempt this procedure to recover islets from the undigested tissue, because even in many cases, in our experience, from the undigested tissue, we did a histological analysis. Still, there are good number of intact islets were present. So using this approach, maybe we can recover an islet from the undigested tissue. So this is for discussion. So if any group have attempted this procedure or tried, so maybe you can share your comment at the end. So using this procedure, the transplanted outcome shows 4 out of 5 patients were insulin independent for quite some time. So in one case, they had a pre-mild diabetes. So it's the highlight is the procedure works. In summary, so this presentation was focused only on the severely fibrotic pancreases. So it is important to dose the enzyme based on the degree of fibrosis. So then the key approach is delivering the enzyme, because it's very difficult to introduce the enzyme through the pancreatic duct, especially from severely fibrotic pancreases. So we use a parenchymal enzyme distension and trying to collect the yearly released good islets by a recirculation approach. And once again, to give you a summary, so this is a grass morphology comparing between the intact pancreas from cadaveric donors and the severely fibrotic pancreas from the chronic pancreatitis cases. So in the cadaveric donors have used a standard approach. So here, so the intraductal enzyme injection and the standard distension time of 12 to 15 minutes, and the enzyme dose is less than 20 inch unit per gram. So in case of severely fibrotics, we have to slightly modify the procedure from the standard approach. So by dosing the enzyme appropriately depending upon the fibrotic nature of the pancreas and prolonging the distension time to make sure the enzyme distributes throughout the pancreas, especially the cases like severely fibrotic, the ducts are collapsed in most of the time, and collecting the enzyme earlier and continuing the recirculation by putting back the enzyme to have maximum digestion of the pancreas. So these are the key approaches to recover the maximum number of islets from the severely fibrotic pancreases. So, and once again, I'm highlighting this publication. So this was the publication by Morrison et al. Indicating that the number of islet transplanted is the likelihood of the insulin independent. So the more number of islets, it's the better the transplant outcome. So based on this, and this is a very straightforward model compared to the cadaveric donor islet isolation done for type 1 diabetes. So here there is no immunosuppression requirement and it works. So our goal and approach to recover the maximum number of islets from the given pancreas on the day of isolation is the key for the success of islet transplantation outcome. I thank the University of Minnesota Islet Transplant Program, University of Louisville, and the Colligo Therapeutics and the Vitas site. And I'm thank you, every one of you, for listening to the presentations, and I'm ready to take your questions. Thank you.
Okay, let me just stop in. So I think the results. Thank you very much, Gopal, for the webinar, and we'll get to the Q&A very shortly. We want to ask you to respond to 2 survey questions that will appear on your screen shortly, and any response you can make is gratefully appreciated. Before I started the session, I wanted to let you know that when we first started this with Pilo Biotech, we thought that we would do these bi-monthly. It's actually probably better to do them quarterly. We already have a next webinar planned for the second quarter in 2021. It will be to discuss collagen degradation activity, collagenases, collagen degradation activity, and we are honored to have Josh Saccone from the University of Arkansas also participate in this webinar, and he's been intensively studying the mechanism of collagen degradation in his lab since their initial publication on the structure of C histolyticum collagenase structure function in 2003. If you have any questions for or suggestions for future webinars, please send me an email to my company email address, rcmccarthy@vitasite.com, or if you forget that, you can just send it to me at vitasite@gmail.com. So, without further delay, and I think Bala will join us now as well, I'm going to start seeing the questions that happened that are on the chat. Just to let you know, if you want to send everyone in the chat, everyone will see your question. So Yong Wang asked, what is the temperature maintained after first islets are collected? Gopal?
So we maintain temperature, the standard temperature, so somewhere like 32 to 35. So because in order to continue to have the digestion, so we maintain the temperature.
So after spinning it, they then kept cold, and you get the pellet, and you take the enzyme out. That's at probably 37, and you just store the islets cold.
Oh, so after collection, so that's undergoes a regular process. So it's at the 4 to 8 degree centrifugation.
Right.
So we spin at 800 RPM to collect the islets. So once the islets are collected, it's saved in the cold temperature. So the enzymes will put back in the circuit to continue for the digestion.
Okay. Julie Kirkanti asks, thanking you for the presentation. And what do you do when the pancreas is full of blood?
So we have to wash in the HBSS. So we experience a case with full of blood. So in that case, very particularly, the islet density was very low. So it was floating. So we have to add an additional serum to bring down the islet to make it as a pellet. So that was the main difficulty we had.
Okay.
So otherwise we had to wash it well.
Bob?
Yes.
Can you hear me? Maybe I can.
Yes, I can hear you.
Some feedback on this. Julie's question. Generally, we prefer not to perfuse the organ after pancreatectomy because it's a short cold ischemia time. We don't want to inject any UW kind of compound, in the back table. So there will be a lot of blood in the pancreas. So I would say my experience or our experience, we don't see any kind of inhibition in digestion or other kind of issue. The Riccardi chamber is full of, red color, enzyme solution. Even then, it continued to digest. In my opinion, the presence of blood, it doesn't cause any inhibition in digestion.
Yeah, I think that's just a comment. There's a lot of debate on that because the problem with blood is you have alpha-2 macroglobulin, and you will not inhibit the collagenase activity, but you will really dramatically affect the protease activity. I had heard, just as an aside, and it's anecdotal, from Greg Zott, that in fact what he did when he ran into this, he just re-injected the organ, and he got with the full dose or added another full dose of enzyme, and it worked. But the biggest problem is the inhibitors, and it may be like you're saying, Bala, you cut that down where it won't affect it, but and if there's a lot of heme, by the way, the collagenase will be inhibited as well. That activity will be.
I'm sure, during pancreas dissection, we try to remove all the vessels which are kind of, right on the surface of the pancreas. But I'm sure there will be internal vessels, clogged inside. So generally, as I said, our preference is not to really flush the pancreas with UW after procurement. That's one. That's why, we directly proceed with the isolation.
Okay. So Rita Bottino asked the question, what is the percentage of human albumin in the medium during the collection phase? Gopal?
Yes. So we use a concentrated in the Almayer flask 1, and it's a 2.5% HSA is used.
Okay. Carolina Golab asked, what is your procedure? How do you modify the perfusion digestion when calcification in the duct is present? So this gets into the blocked duct tissue.
So as I mentioned during the presentation, so that's the major challenge. So when we get the severely fibrotic pancreas, so we have to do the parenchymal distension, enzyme distension.
So you just get around it by doing a lot of
A
injections.
lot of injections around, yes.
Hannah Schultz asks, do you have experience with purification using the Cobe? What is the average pellet volume for those pancreases?
So especially in severely fibrotic cases, so the pellet size is very small. So it may be like 1 cc, 2 cc. It really depends upon the severity of fibrosis. So we may not have purification in most of these cases.
I want to add to what Hannah mentioned, because, I mean, of all the centers, of course, Minnesota has done on their website greater than 700 islet isolations for TP-IAT. And I know, and you've published on this, is that you do test gradients when you have a lot of acinar tissue that contaminate the islets. But I want to ask, and it's related to Hannah's question, in cases where they're really severe fibrosis, how often do you actually do a purification when you get those organs? So, for example, you saw a whole host of different organs when you were in Minnesota because of the experience of that center, whereas in Louisville, you saw mostly very severe fibrotic pancreas. And I just wonder if you could comment on that.
Sure. So yes, so in Minnesota, it was a great opportunity to get an experience with a different degree of fibrosis, pancreasis. So the minimal change pancreatitis, it's almost similar and comparable to the cadaveric donor. So when we process a pancreas, the pellet size it's somewhat similar. So what we see from the cadaveric donor pancreas. So on the moderate pancreas, it depends upon the degree of fibrosis. Still, there are many times we get a good pellet size from the moderate fibrotic pancreases. But in the case of severely fibrotic, the pellet size is always small. So we get a good pellet size from the minimal pancreatitis cases.
Okay.
Yes, so exactly the same point. I would say 99% of the time you don't require purification, if you define your pancreas as severely fibrotic, because, the total parenchymal cells, in the entire pancreas is very small. So almost 99 to 100%, there won't be any purification.
Okay. Carolina Golub asked another question: in which percentage of cases do you need to perform purification? Which I think we might have just answered in that response. So I think we've answered that question, because let's see what kind of modifications you introduce in purification. And that I will just let you know at this time, if you go to the little files tab, you should be able to download a list of references, and in there, in the second edition of a book called Islets of Langerhans, there's an extensive write-up of what was covered here, and it's the University of Minnesota experience in technical issues surrounding these isolations. Yong Wang asked, after enzyme infusion, what sizes of pancreas tissue do you cut into? Are smaller pieces better?
So especially from severely fibrotic, as soon as we see the pancreas size, we decide what chamber we have to use, whether it's a 250 ml chamber or 500 ml chamber. So that makes the enzyme concentrated. So for a 30-gram pancreas, if you use a 600 ml chamber, the enzyme gets diluted. So I'm coming to the wrong question. So we try to cut as maybe like 2 mm to 3 mm size to make the digestion better. So we try to cut it as small as possible.
Okay. Wang Sui stated, one quick question: what is the acceptable lowest islet dose for infusion according to your experience? That was one of my questions as well. I mean,
So,
when do you say we can't, and your team decides clearly? It's not only the islet isolators, but it's the clinicians based on their experience that you just say we can't transplant any islets. What is that number?
so it's especially the person who handles the pancreatic trimming distension has a better control to decide the enzyme distension, because the person who is handling the pancreas can be able to feel the firmness. So by looking at the morphology, sometimes initially we think the degree of fibrosis may be like 7, 8. After cutting the pancreas into 2 halves, so you can able to see more in detail whether you have a calcified or the parenchymal tissues around is there, or it's all replaced by the fibrosis. So at that time, so we make a decision based on the firmness. So at what dose to go for. So the minimum for severely fibrotic we go is 26 Wunsch unit, and the max is 30 Wunsch unit.
Yeah, Gopal, I think he's asking after the end of the procedure.
Yeah. I think, Bob, maybe I can answer to
Sure.
this. Our product release criteria is about, if it is below 10,000 islet equivalents in total, generally it doesn't meet the release criteria. So
Okay, that's
95% of the time, achieving 10,000 islet number, definitely 95% of the time we achieve that number. In our experience, in few cases, the islet yield was below 10,000. With the, the approval from the surgeon, we can release the product with the proper deviation and definition of, even with the low islet numbers infused.
okay. Yagan Kalavarathan, excuse my mispronunciation, asked, what is the more effective to digest fibrotic pancreas, increasing collagenase dose or the protease dose? That's a good question.
So if it's a young donor pancreas, yes, straight away I would say it's increasing the protease would help to have a better islet release. But in case of severely fibrotic, it's dose plus how we introduce the enzyme into the pancreas. It's very critical for digesting the pancreas. So I would say is both. For example, like so when we have a 30-gram pancreas from a severely fibrotic case, so we dose a 25 Wunsch unit. So for 30 grams, we end up 750 Wunsch unit.
Yeah.
But when we dilute this enzyme in a 600 ml chamber, so it may not be effective. So that's why we try to go with a smaller chamber. So it's the ratio of collagenase and protease, both is important for having a better digestion from fibrotic pancreases.
Yeah, I think maybe I would like to add my comment. If the question is, which is really important, collagenase is important. The role of proteases, predominantly to, digest the peri-islet based good site, good islet morphology. So in severely fibrotic cases, we are having a lot of difficulty in just digesting the pancreas. So we need a more collagenase. Even I would say very minimal protease would be sufficient, because the role of proteases, here in this type of cases is very minimal in my view.
Yeah, I'll add my 2 cents. Is I would say we don't know. Simply because it's right. There's never been any studies on this. All your stuff you did at Minnesota was incremental, right, Bala and Gopal?
Yes.
Yes.
So there was never really, it worked, which is great. But like I said, we're consistently consistently surprised how little things you need at times. So Julie Kirkanti asks, some patients have been stented and thus there is more risk of having an islet prep contaminated with bacteria, etc. You probably transplant before culture, but in your experience, do we need to put in specific antibiotics, antifungal agents in the culture media? We only add penicillin and streptomycin to these, and I think the preps can, because the preps are contaminated. Can you comment on that?
So in case of auto-islet transplant, we don't culture the islets, and so it's right away it's get transplanted immediately after transplant. So this is known in case of chronic pancreatitis. We expect to have microorganisms. So the surgeon will initiate the prophylaxis antibiotics immediately after infusing the islet. So that covers the wide range of to cover the bacteria.
Yeah, so you guys always take, from what I read of the procedures, when I read that review that's on the reference list, you guys always take 3 ml for complete bacterial contamination, but those results aren't known, right, till way after the cells are delivered.
Yep. And then, the answer to Julie's question, there are many published papers on this topic, whether, the final product, contamination in the final product after infusing the islet cells, whether it is causing any significant problem to the patient or not, clinical problem. The answer is no. There are, I would say, 5 to 6 papers are available on this topic. From the time when we dissect the pancreas from the duodenum, it is always a challenging for chronic pancreatitis cases. There is a 90% possibility of contamination, especially if the stent is there. Definitely the product will be kind of contaminated. So the surface decontamination in the initial procedure at the before we inject the enzyme, maybe that really helps to kind of get rid of some of the organism. And during several washing steps, in the entire isolation process, that is also causing a lot of elimination. But even, many chances the final product will be contaminated, especially if there is a stent and all. But I don't know whether those contamination causing any clinical significances.
Okay. Julie had a follow-up question. Do you use ice to cool the cells, or do you have another system to cool your tubes down post-digestion?
Yes. So yes, I will comment on this before I just going back to the Rita's question. So she asked about the concentration of the HSA used in the collection medium.
Sure.
It's a 10%.
Okay.
So
and how do you cool your tubes? It really gets down to probably in your when you remove the islets, you just put them in an ice water bath or something, ice water slurry, or.
So initially, so in those days we used ice and ice cold waters. Then
that's right.
We assessed, like we tested the metal beads, the metal beads, which holds the temperature better compared to the ice. So we have been using metal beads. Yes.
Yeah.
What do you mean by metal beads?
It comes as like a small seed metal beads. So we freeze the metal beads ahead of time. So on the day of procedure, we take these metal beads and keep all of our digestion collection medium, the collection recombination.
And the reason for that is you don't want any water in your GMP or something. Yes,
that's another way,
okay.
As well as better withstand of temperature.
Yeah.
Okay.
Instead of bringing the wet ice to the GMP lab,
yes,
these GMP standard, these beads are available. They are tiny beads.
Interesting.
Maybe 3 millimeter size beads are. Then you can freeze those ones and then use it at the time after pancreas digestion.
Okay, that's interesting.
You can use it.
Okay, Yagan asked the question, what is your protocol to remove calcium from the islet pellet, or do you remove calcium from the islet pellet?
So it's pretty much the same question Dr. Wang Sing Ku asked too. So especially when we see the calcified tissues, so at the time of trimming, so we try to remove it as much as we can. So during the digestion process, we cannot eliminate, but at the end of the islet product, we try to manually purify the islet from the calcified tissue. So that's how we try to remove the calcified tissue from the final product. We try our best to recover the islet from this calcified tissue, but still there may be a trace we cannot eliminate.
Okay. Wang Sing Sui, could you make some comments on how to handle the severely calcified pancreas during digestion and the final cell product preparation?
Yeah, I just answered. I mentioned that it's the same question.
That's fine. Okay, sorry about that.
In order to elaborate the answer for this, if the calcium crystals are larger size, whenever is possible during enzyme distension, before you put it in the pancreas, try to remove those large calcium clusters. And after digestion, yes, there will be a calcium crystals with tissue pellet. What you do is basically you try to collect both into a larger, like a 25 ml pipette, and hold it for us, for a few minutes. Calcium crystals, they tend to sediment at the bottom. You try to expel those calcium and take that supernatant. Do this procedure multiple times and try to eliminate as maximum as possible all those calcium crystals.
Okay. Carolina Golub asked, do you plan your islet isolation procedure based on the pre-pancreatectomy medical results, e.g. the duration of pancreatitis, CT scans, etc., or just based on the visual observation of the pancreas after you receive the organ?
Definitely, we review the medical history. We try to know about the prior history. That gives us in a better position, like what to expect on the day of isolation. So we review ahead of time all this medical history.
Hannah Schultz asks, have you isolated from patients that are MRSA positive?
So not that I remember. So I know it's a hospital-associated methicillin-resistant Staphylococcus aureus. We haven't. I don't remember, to my knowledge, any cases. But Dr. Bala can comment whether he has any experience on this MRSA.
Yeah, I don't really remember anything specific to that.
Okay. Rita, I think we've answered this question. Asked, thank you for the. Okay, she's just thanking you for the additional clarification of this HSA. Don Fisher asks, could you please give us the company and catalog number for those metal beads, so we can send out emails to all, I guess, afterwards, if you don't have it in front of you, Bala or Gopal.
Sure,
and Hannah's asking the same question. And Yagan asked, have you tried purification of the calcium pellet using density?
So especially when we see this type of calcium only on the severely fibrotic cases, and most of the time the pellet ranges from 1 cc to 2, 3, very minimal. So we never attempted any purification. So we try to do only a manual purification. We haven't tried any density so far.
Okay. I'm going to ask a couple of questions that, first and foremost, I was the one that kind of included the Hinshaw method in here, and it was in this presentation, and it was simply because an ex-Lilly employee who left Lilly did a postdoc at Scripps, and he was trained by Dan Hinshaw how to do it. And they actually did it on rat islets. This was, he was just doing a side project, and it worked very well. And and corrected diabetes in syngenic streptozotocin treated rats. And I was intrigued when he told me it, but it wasn't until when we got deeper into this that I found, this may have some merit. Bala and I did talk to Dan, who's a retired, I think, general surgeon at the University of Michigan. But I think the value of just bringing this up as an out of the box is that item is that it may work, but I would strongly urge you to say this is a research study. If you want to do this, because as you saw from the notes on the slide, there was no DTZ used at this time. I mean, this was 1981 when this publication occurred. So if you want to play around with this, it was a pretty simple procedure where they actually just pressed the minced tissue through a mesh screen and did differential centrifugation. So that's the only comment. To if you want to try it, do it first as a research study, see what the islets look like, and then you can consider whether you're going to incorporate it into the dose that you transplant. And the second thing I wanted to note is you noted, Gopal, that you adjusted the dose of the enzyme by somehow categorizing the severely fibrotic pancreas. Can you give any additional details of how you make that decision? How do you put the organs in different categories? Gopal or Bala?
But basically, this is like your gross morphological observation.
Okay.
And how you really feel the texture of the pancreas. So 3 ways, morphological observation, you feel the texture, and when you cut the pancreas, you can see, how much is the parenchymal cell versus, fibrotic tissue. You can clearly see that, after cutting the pancreas into few pieces. So it's a arbitrary assessment.
So it really gets down to it's based on experience that you had at Minnesota and you have in your head, but it's not written down.
We try to correlate with the histology, but it's very difficult to.
That's what I was wondering. It's kind of a feel, right?
Exactly.
It really gets down to. Well, I think the hour is just about up. This is great discussion. Thank you for all your questions. Julie asked one last question. Are you adding any extra calcium to your enzyme solution? Gopalabala.
We don't.
That's what I was going to say.
Yeah.
I can comment on this as well. This is a hot question, and basically, it's I think the most interesting paper, because we've had this question come to us, and the most interesting report was actually a study that was done at Uppsala, where they showed that actually the free calcium does decrease during an islet isolation procedure, but from a biochemical standpoint, it doesn't impact the enzymes because you can do it at less than a millimolar. So it's hard to know what's going on with that. So before closing, again, I thank you for your participation. We will send out the information to all of you on those metal beads in a separate email. We'll also, if you hadn't done it, we'll also include a copy of the reference list as well in that same email, since we're sending it out, or if you haven't done it already, you can download it. And I just want to remind you, you'll get another announcement for a discussion of collagen degradation activity assay, and most importantly, the role what is collagenase doing, actually, is from Josh Saccone at the University of Arkansas. Again, I encourage you, if you have any ideas for additional webinars or topics for webinars, just drop me an email note. Again, I'll sign off, and Gopal, thank you very much. And Bala, thank you very much for participating in the discussion, and thank all of you who participated in this webinar to make it successful. So I'll sign off, and everyone have a good day and a safe day. Bye.
1 second, sir. 1 second.